will be retarded because
Sure.
thalamus is called the
Yeah.
relay station.
Yes.
Because all stimulus coming from the brain stem so
Goes through the thalamus, yeah.
go first to the thalamus.
Yes.
And so are they directly, so all stimulus go also to there, go parallel, go through pulvinar?
Well, a stimulus can go through the thalamus and then go through the amygdala, or it can go directly through. So you can elicit a fear response before you've appreciated cognitively that there is a threat. So there are two mechanisms. So one, you can go from auditory or visual cortex directly to amygdala, and another way is they can go through the thalamus and come down as well. Is that okay? Does that make sense? So what does the amygdala do? So we've seen that it orchestrates the fear response if a potentially dangerous or ambiguous item in your environment, you can orchestrate this fear response. Research into the amygdala tends to focus on aversive stimuli, but remember that the amygdala also reacts to appetitive stimuli, so positive things. It has a really key role in fear conditioning that we'll talk about a little bit. And it's a modulatory organ in many ways, in that it doesn't store memories. It doesn't store declarative memories anyway, but it does modulate the formation of those memories. And it also modulates attention and visual perception. We've seen that through the basal forebrain it enhances general attention and perception towards relevant stimuli. It has a role in social behaviour that we'll see, and it has other roles in aggressive, maternal, sexual and ingestive behaviour. So really broad-ranging. And you can see why it's important in psychiatry. It does all of these things, or has a role in all of these things. So the first group to really kind of prove that the amygdala had a role in these functions were Heinrich Kluver and Paul Busey in the University of Chicago in 1937. Like I said, they removed the anterior temporal lobe from monkeys and observed their behaviour afterwards. What they observed was a variety of socially and motivationally inappropriate behaviours. So monkeys would approach all objects the same, whether it was an aggressive dominant male or a banana. They would lose that what's called motivational salience towards things. So they weren't able to tell whether things were dangerous or not. They exhibited hyperorality. So they tended to explore objects with their mouths, and hypersexuality. They showed reduced aggression and reduced fear response. And what you saw was if you removed the anterior temporal lobe or the amygdala in a socially dominant primate, what happened is they gradually sort of fall down the chain of dominance and become more submissive and eventually die. So it's a critical structure for fear response and for survival. We know from electrophysiological studies, baseline studies of the amygdala, is that the amygdala has a low baseline level of activity, so it sort of sits there waiting for something to happen. And when a novel stimulus in the environment, they elicit a very rapid response. That response attenuates the more you expose the organism to the stimulus. So it reduces over time, so the amygdala realizes that it's not a threat and reduces the response. You can overcome this inhibition if you represent that stimulus in a novel environment. So it becomes potentially salient again. One of the really important things about the amygdala is if there's an ambiguous stimulus in the environment, if the amygdala doesn't really, or if you don't really know what it's there for, the amygdala will aid in attributing salience to it, to say whether it's dangerous or whether it's desirable. A lot of research into the amygdala looks at facial expressions. Facial expressions are a fairly robust way of activating the amygdala in fMRI studies and so on. The amygdala responds robustly to fearful faces. But again, if you keep showing a person the fearful faces, that response falls off. But if you show surprise faces, the signal in the amygdala isn't quite as high, but it's more sustained, so it doesn't disappear over time. And this is possibly because the surprised face is more ambiguous. A fearful face clearly shows you that something's up, something's wrong, something bad is going to happen. But a surprised face could be because someone's about to be attacked or because they've just walked in on a surprise birthday party. So it's a more ambiguous phenomenon. So what the amygdala does is it will attempt to lend salience to that ambiguous data, ambiguous stimulus. The amygdala has a central role in fear conditioning, and the bulk of research into the amygdala in rats and monkeys has been in fear conditioning. The cells of the lateral amygdala display a phenomenon called neuroplasticity, which means that they can adapt and change, and they store the association you see in classical conditioning. For anyone who isn't familiar with classical conditioning, I think most people are, but it's the pairing of a previously neutral stimulus with an aversive stimulus. So you might have a rat in a cage, and you electrocute, you send a shock up through the rat's feet, and the rat startles. So that's the response, is the potentiated fear startle, or the potentiated startle response. The rat jumps, and that makes sense. So the electric shock is the unconditioned stimulus. And then if you start to pair that electric shock with a flash of light, the rat very quickly will learn to startle in response to the light alone. And that can happen after only one or two pairings. If you keep doing that, if you keep showing the light without the electric shock, the rat at first startles, but gradually we see a phenomenon called extinction, which is where the response attenuates, disappears over time. So the rat first starts to startle, you shine the light again, startles a little bit, shine the light again, startles less, and over time you see extinction of the pairing between the unconditioned and the conditioned stimulus. That extinction isn't forgetting. You're not forgetting the association between the two. Rather, it's an active remembering, or an active increase in knowledge that the association is no longer valid. And remember, we saw that the basal nucleus was functionally between the lateral nucleus and the centromedial nucleus. So, and their connections to the orbitofrontal cortex. So what happens with extinction is that your cognitive process realizes that the connection between the two is no longer valid, and your basal nucleus actively, I think we have a slide, actively stops the transmission of the fear response through here. So extinction is this active blocking of the transmission through here. That's why extinction can reappear so quickly. Extinction can reappear just with the passage of time. Extinction can disappear just with the passage of time. So if you leave the rat for a few days and then come back and shine the light, it will startle again, even though it was previously extinguished. And it's thought that ventromedial prefrontal cortex, via their projections to the basal nucleus, is what is instrumental in stopping that. And that obviously has implications for anxiety disorders, people with post-traumatic stress disorder or simple phobias. What you would preferably want to do is enhance extinction so that classical conditioning fear response doesn't happen. And we'll talk about that a little bit later on. Recent research coming out of the States called Mike Davis makes a distinction. He writes a lot about the neurobiology of fear and anxiety. He makes a distinction between fear and anxiety. So anxiety is that background level of sort of increased arousal mediated by the bed nucleus of the stria terminalis. And fear, which is that startle response, is mediated through the amygdala and the outputs of the centromedial amygdala. So if you imagine you're walking out of here tonight through Camberwell to your car down a dark alleyway, and you feel on edge, you feel frightened, that's the bed nucleus of the stria terminalis that's causing that increased arousal. If you then hear a loud noise, like a car backfiring, and you jump, that's your amygdala. So the stria terminalis potentiates that response, so you're more likely to jump if you're in that increased state of anxiety and arousal. But just to know that there is a sort of a distinction between those two phenomena in the research. The amygdala has an important role in modulating memory. It doesn't store memories, except it does store some implicit memories. If you think of the association in classical conditioning, it stores that information. But it doesn't store declarative memory, so it doesn't store memories for events or information or facts. But it does have a role in modulating how memory is stored. I've written a dog example here. It's not supposed to be there, but I have an example involving a dog. That's a little bit unprofessional to leave it on the slide. So again, you're driving home tonight and you see a dog at the side of the road. and nothing happens, you're unlikely to remember that event. But if you're driving home and the dog runs in front of the car and you have to swerve, you have a fear, a startle response mediated by the amygdala, and you have to swerve, of course you're going to remember that for months and possibly years afterwards. So what the amygdala does, these are the stages of memory: encoding, storage, and retrieval. And these are the effects that the amygdala can have at the various stages. So like we've seen previously when we were looking at connectivity, the amygdala can increase your attention, it increases your perception, it narrows your perception to sort of focus on a relevant stimulus, semantic elaboration via connections with the orbitofrontal cortex, hypothalamic pituitary axis activation, stress hormones. And then in terms of storage and retrieval, the amygdala can enhance those processes as well. There's good human research to support that. If you do a functional MRI on people who are experiencing aversive stimuli, the amount that they recall later is directly proportional to how much activation there was of the amygdala. So the more active your amygdala is, the more likely you are to remember the events afterwards. Stress hormones activated through the hypothalamic pituitary axis by the amygdala can also enhance memory. If you give animals adrenergic agonists, so substances that act like adrenaline, during the encoding process, they're more likely to remember it afterwards. And if you block adrenaline, then the enhancing effects of the amygdala on emotional memory storage are blocked. One thing to note is that at the extremes of emotional arousal, it's possible that this process can be sort of perverted. So if you're extremely anxious or aroused, high levels of cortisol can block recall. So that's a sort of pathological extension of this helpful mechanism. The amygdala has a role in social behaviour. A lot of the information we gather in visually and auditory information is socially relevant, and the amygdala has a role in processing and modulating that as well. Especially, as we've seen, ambiguous behaviour. And if you have a lesion of your amygdala, you can't make sense of that ambiguous behaviour, like the surprised face as well. It also has a role in theory of mind. Theory of mind refers to the ability to infer another person's cognitive state by looking at their face or hearing what they say. The research into social behaviour in the amygdala goes back to Kluver and Busey, but Dix in 1968 performed bilateral, specifically amygdala lesions in monkeys. He found that if you did this at 2 to 3 years of age, there was a transient kind of social impairment. There was difficulties with mother-infant bonding. But the monkeys then grew up to be pretty similar to their peers in terms of social behaviour. So there's some sort of plasticity. Some associated structures are making up for that deficit. But if you did it to adults, they persist in social abnormalities, like what we saw in Kluver-Busey syndrome. They fall down the social dominance hierarchy, and they display a variety of socially maladaptive behaviours, and they eventually die within a month of the amygdala lesions. Bauman in 2004 sort of replicated a lot of these findings in a neonate, so in a newborn monkey. If you induce bilateral amygdala damage, again, there's mostly normal social development and broadly kind of normal social behaviour when they're adults, but they have difficulty modulating their social behaviour. So we thought of the amygdala as a kind of a modulatory structure, and they have difficulty modulating the levels of social behaviour as an adult, but mostly normal social development otherwise. So wouldn't it be great if we could remove people's amygdalas and see what happened? We can't. Ethics boards tend to be pretty sticky about that kind of thing. But there are some disorders that in which we see amygdala lobe pathology. Temporal lobe epilepsy often affects the amygdala, but unfortunately it affects surrounding structures as well. Surgery for temporal lobe epilepsy involves the removal of the hippocampal amygdala complex, but to varying degrees, and so you don't get a very clean picture of what happens when you just remove the amygdala. Herpes encephalitis tends to involve frontotemporal regions, but again, not specifically, and nor do these disorders here, although they can affect that area. But there is a disease called Urbach-Witte disease. Is that right? I think it's probably pronounced right. Urbach-Witte disease is a very rare autosomal recessive lipid storage disorder. It's a metabolic disorder. The clinical features are things like thickened skin and thickened mucous membranes in the mouth. But it has this very unusual feature as well of mineralization, calcification of the amygdala bilaterally in some patients. These are CT scans of a patient with bilateral calcifications. This shouldn't be white. Bone is white in a CT scan, bone and fresh blood, and calcium, and this is calcification of the amygdala. So the amygdala is gone, really. It's been pathologically removed. Adolf, Tranel, Damasio, and Damasio have a couple of patients, SM and AP, who they've studied over the last almost 20 years. And they've done a variety of neuropsychological and behavioural tests on these two patients, both of whom have Urbach-Wiethe disease and both of whom don't have functional amygdalas. And so what they see is both patients at interview present as being slightly socially inhibited, but not terribly noticeably. And they've been assessed as having no major psychiatric illness. They don't have depression, they don't have schizophrenia, they don't have autism, they don't have personality disorders. But they do have these slight discrepancies compared to normal controls. When they look at pictures of people's faces, they're impaired in judging the trustworthiness of the other's face. This is a theory of mind. They can't make adequate use of visual information from around the eyes. When we look at a person's eyes, we get most of our information about the person and what they're thinking from their eye region, and people with amygdala lesions can't do that. There's people might know more about this than I do, but there's a test that's done where you show a person moving geometrical shapes. Normal controls tend to attribute motivational and emotional meaning to the shapes, whereas people with amygdala damage don't. And that's this is approximately the same profile we see often in people with autism. Again, a patient SM is older. She's been studied more. When she looks at the faces, she fails to fixate in the eye area, where normal people will look around the eye area. And she fails to explore faces in general. Doesn't seem to be terribly interested in faces when she's presented with pictures of people's faces. So that's an overview of what the amygdala does. So it's important in the orchestrated fear response. It's important in evaluating ambiguous data, importantly. It's important in social function and theory of mind. So what happens to the amygdala in psychiatric illness? If you look at these disorders here, it would make sense that the amygdala would be affected, considering how central its role is in social and cognitive function, cognitive evaluation of things. The studies that have been done in psychiatric illnesses, originally it was post-mortem histology from patients, looking at cell packing density, size of structures and things like that. Newer studies like structural MRI, functional MRI, PET, SPECT, and most recently DTI tractography. The problem with these studies is that they don't have the spatial resolution for us to look at different nuclei of the amygdala. All we can do is to say, yeah, the amygdala is activated or not activated, or slightly bigger or slightly smaller. We can't say the lateral amygdala is affected or the centromedial amygdala is affected, and that's the major. But I'll talk about that again in a second. That's the major shortcoming of these studies. So anxiety disorders. We saw that the amygdala was crucial in fear conditioning and extinction, so it makes sense that it would be involved in anxiety disorders. What we see in post-traumatic, I think the most robust findings are in post-traumatic stress disorder and social phobia, predictably. Post-traumatic stress disorder. So there's amygdalar hyperresponsivity to traumatic cues, but also to non-traumatic and general emotional cues. So the amygdala is kind of hyper-responsive. And the level of activation you get correlates positively with the symptom severity that the patients have. So that's a nice kind of, the more amygdala activation you have, the more severe your PTSD symptoms are. It also correlates with medial prefrontal cortex activity, again, functional MRI studies. And that's quite nice if you remember that the frontal cortex is what modulates the transmission of information through the amygdala in fear conditioning. So in PTSD, you have this very potent connection between a variety of stimuli, which can be noises, visual information, or memories of the event, and then a very potent anxiety and fear response. And so it's nice to see that prefrontal cortex activation there, which kind of lends a little bit of credence to that. And social phobia. I found this series of studies last week, and it was my favourite one because I found myself quite nervous and anxious while reading it. People with social phobia have greater amygdala activation doing public speaking than when doing speaking in private. And the level of the activation, functional MRI again, correlates with the self-reported fear level. So the more amygdala activation, the more afraid and anxious and nervous they feel. This is modulated in some degree by genetic variation of the serotonin transporter gene. But also, the anticipation of speaking or the memory of speaking can cause the same fear response and the same amygdala response on fMRI. They also show an increased amygdala response to fearful faces. Excuse me. So that's anxiety disorders. In schizophrenia, we generally think of schizophrenia in terms of psychotic, positive psychotic symptoms, delusions, hallucinations. But of course we know that vitally important is cognitive, social and occupational problems in schizophrenia. So it makes sense that the amygdala might be involved there. The notion of salience is very popular and important in schizophrenia. The idea that people with psychotic disorders tend to attribute negative attributes to neutral stimuli. So they see something that we wouldn't think twice about, but there's a fear response generated, and this could be the first step in then a delusional elaboration of that stimulus. And this is possibly the first step in where delusions come from, positive psychotic symptoms. So there's indirect evidence for involvement of the schizophrenia in involvement of the amygdala in schizophrenia. People with schizophrenia have facial expression recognition deficits. They tend to pay less attention to threat-related or affect-laden words, but they attribute threat to neutral stimuli, like I said before. So things that we would not attribute any kind of threat to, they view as threatening or aversive. Direct evidence of amygdala involvement. There's dysfunctional medial temporal lobe activity. In the amygdala, it's not consistently increased or decreased. Sometimes we find that it's normal. But it is dysfunctional in some way. And this possibly may be an increased response to ambiguous stimuli or a labeling of neutral stimuli as aversive. In autism, which is the area that we are doing research in predominantly, the amygdala has been an area of interest for many years. These are the three symptom clusters in autism, and the reciprocal social interaction is the bit we're particularly interested in. The first studies done in the 80s, Bauman and Kemper did post-mortem histology on 9, I think, adults with autism. And they found abnormalities in cell packing density, and they found that the neurons were smaller. Their results were confounded significantly by the fact that most of their patients had seizure disorders, and seizures affect that area of the brain as well, so they may not be valid at all. And with the technology they were using then, there were various post-mortem artifacts that they couldn't account for. Cynthia Schumann in 2006 kind of redid a very similar study. Looked at post-mortem histology with updated techniques and used stereotactic techniques, and found that there were fewer neurons in the amygdala, but she didn't find any increased density. Structural MRI studies of the amygdala in autism have provided inconsistent results, but Cynthia Schumann in 2004 did something interesting. She separated her group into 8 to 12-year-olds and then adolescents and adults. She found a larger amygdala in the children, but a normal-sized amygdala in the adults. So the amygdala isn't enlarged or reduced in size in adults with autism. Did I say schizophrenia? Sorry, autism. But there is an abnormal developmental trajectory. So the normal increase in size in your amygdala from when you're a child to an adult doesn't seem to be the same in autism. Why that is isn't clear. Simon Baron-Cohen wrote about the amygdala theory of autism in 1997. We know that people with autism have deficits in their ability to infer mental state from eyes, which is the same abnormality that we saw in patients with the bilateral calcifications of the amygdala. Controls, when they look at fearful faces, tend to activate amygdala and superior temporal gyrus, functional MRI, whereas patients with autism spectrum disorders tend to activate their frontotemporal region, but not the amygdala. suggesting that they're interpreting the faces in a sort of a higher cognitive fashion, but not via the amygdala in the way that normal controls do. One of the problems with this research is that people with autism tend not to look at eyes, which is a confounder, because if you don't look at the eyes, then you can't infer the mental state. Pierce in 2001 found that the amygdala wasn't activated when people with autism spectrum disorders view unfamiliar faces. In order to try and correct for that confounding factor, which is that people with autism tend not to look at eyes, and so, how valid are these results? Dalton saw that patients with autism who do spend time looking at eyes, that there's a correlated increase in amygdala activity. People with autism find looking at the eyes aversive, unpleasant, and more amygdala activation when viewing familiar and unfamiliar faces. Chris Ashwin in 2007 saw less activation in the left amygdala when viewing fearful faces compared to controls in patients with autism spectrum disorders. Psychopathy is an interesting area as well. We know that people with antisocial personality disorder have impaired orbitofrontal cortex and limbic structure activation during aversive conditioning. They don't, and that they're less able to learn from aversive conditioning. They have decreased activation of amygdala-related areas during facial fear processing. This is Dr. Craig and Dr. Catani's study from last year. This is, again, diffusion tensor imaging tractography, outlining white matter tracts in the brain. This is the uncinate tract connecting the mesial temporal lobe structures to the orbitofrontal cortex. And you can see that the significant result here, well, there's reduced fractional anisotropy in both the left and right uncinate tract, but significantly in the right. So it's possible that not the structures themselves that are necessarily abnormal, or not only those, but the connectivity between them. So that's just a little bit about psychiatric illness and how it relates to amygdala pathology and amygdala function. What we plan to do here in this department is we have these really high resolution, these 500 micron resolution MRI scans of Sean's amygdala, and for the first time we're able to identify the various nuclear groups which are important functionally. So that's what I've done over here. And as far as I know, that hasn't been done before. So the next move is to combine this with tractography and get a really good idea of what the connectivity of the amygdala is like in human brain in normal controls and in pathological conditions. This is the 3D reconstruction of Sean's amygdala, nestled in here, just ventral to the putamen. This is the anterior commissure coming across here. This is the almost contiguous line of cells coming up to the bed nucleus of the stria terminalis. You can't see, but the claustrum is just here. Lateral nucleus of the amygdala, basal nuclear group, cortical nucleus, and central nucleus. And then this is just a cutaway caudate nucleus in the background there, so you can see it more clearly. So that's it. Just a little overview of the amygdala and what it does and what it doesn't do. Are there any questions? Anything that wasn't clear, or anything that someone wants me to go over again? Thank you.
What is your prediction regarding different methods?
What do you mean?
Autism, so.
In what we'll find? Well, I don't know. I mean, we know there's a structural abnormality in the amygdala. We know that there's a developmental trajectory change in the amygdala. We don't know anything really about the connectivity. I don't know. I don't have a prediction as yet. When I write the paper, I'll predict something.
I have a question actually for the people that I don't know how many of you are doing fMRI in an amygdala. So is anyone working on fMRI and see? Not really. My question was actually how difficult it is to see activation of the amygdala. I think we've seen a lot of this, but papers, I think it's pretty difficult. So when you have when you don't have any activation, it's difficult to say whether that you're not able to see actually there's no activations and the other way around. I think what is interesting about this is actually, though I'm sure you mentioned about Buddha, although it was described a long time ago, we know really very little about it. And so, for example, questions like gender differences, or how the amygdala develops, is still very unknown, a mystery in neuroanatomy.
There is a differential in terms of laterality when men and women, normal controls, look at fearful faces. Men activate their right amygdala and women activate their left. I have no idea what that is.
Well,
I'm sure you do.
The professor at Harvard, he lost his job because he made some comments about gender differences.
Oh, really?
It's a risky area.
That's why I didn't say anything about it.
Exactly, you're wiser than. But I have final questions actually. What is the neuropharmacology? What are the kind of transmitters that?
Well, the Swanson and Petrovich. I'll have to get out of it here. I can't get out of it. They based a lot of their conclusions on neurotransmitter data when they kind of reorganized the amygdala. There's a picture here. There we go. So you can see that the parts that are cortical related are predominantly glutamatergic, and the parts that are striatally related are predominantly GABAergic. Now, I talked a bit about the inhibition of transmission through the basal nucleus by connections with the medial prefrontal cortex, and that's NMDA mediated, and experimentally D-cycloserine, it's an NMDA partial agonist, can increase extinction, and there are trials going on using NMDA partial agonists to as an adjunct to psychotherapy in disorders like PTSD and simple phobias, where what you want to do is stop that transmission through there, and then there's between the bed nucleus of striatum terminalis, connections between there and the amygdala corticotropin releasing factor is an important.
So when we use SSRIs for anxiety disorder, we're probably acting on different targets.
Yeah.
Probably away from amygdala.
Sure. Although there are differences in anxiety disorders in amygdala activation depending on what your serotonin transporter genotype is.
You mentioned about the role of amygdala in approach behavior. I was wondering if you could say a bit more about that. Is it involved with reward processing?
What was the last question?
Is it involved with
Yeah. Most of the research in the amygdala talks about it in terms of aversive conditioning, but it's just as important in terms of appetitive conditioning. So approaching things that are rewarding as well as avoiding things that are aversive. So it's easier to do research on aversive conditioning than appetitive conditioning, but it has an equally important role in that. And you saw in the Kluver-Bucy syndrome, the animals approached things arbitrarily, whether they were aversive or appetitive. So it certainly has a role.
In terms of classification, nomenclature, is the amygdala part of the basal ganglia, the limbic system, or extends by itself?
Well, there's been a debate going on since Johnston in the 20s. So he said that it was an extension of the claustrum. Subsequently, it was thought to be an extension of the striatum. This is, I think, pretty definitive at the moment. Anyway, this is Swanson and Petrovich. Medial and central is an extension of the striatum. These structures here are extensions of the olfactory cortex, and then the newest parts, basolateral, extensions of the frontotemporal cortices.
So it's been divided up.
It's been divided up, yeah. But Swanson and Petrovich say that it's not a functional or an anatomical unit. It's a variety of things that just looks like a kind of that they're all together. They say that there is no amygdala. I don't agree with that because my life would just fall apart if that were the case.
I think that's your take-home message. There's not one amygdala, there are many amygdalas, and it just happens to be there together, but actually they're completely separate.
Yeah.
Okay, fantastic. Any other questions before we wrap up? No? Okay.
Thanks very much.
Thank you very much. I guess the next one is on the 17th of March. Is about
Thanks for that.
lateralization, is about asymmetries of what matter tracks. Not only language, we'll go beyond language. So a bit of what studies have been done to look at asymmetries for language and other tracks, including limbic and projection systems. So if you're interested, 17th of March, 4:30.
Sorry, what about?
Sorry?
What about?